All right, you're free from slides, but you must look at me. Good afternoon. Thank you all for having me here today. And I see so many familiar faces in the room, and it's nice to be here. And it prompts me to tell a story that tags perfectly on with Sally's, which is that for a prior life that I had when I was on the faculty at Tulane School of Medicine, I spent a lot of years trying to work on an effort where you would ask patients a single question in general: how would you rate your health? Excellent, very good, good, fair, or poor. In fact, took a class with David Bates during my fellowship, which is how I probably first got hooked on HIT, because I wanted to build that question into the electronic health record so that at the point of care, the patients would be asked it universally as a vital sign, because that single question, as I hope you all know, is extraordinarily predictive of not only current state, but future state. It predicts future mortality, healthcare utilization, whether that's inpatient, outpatient, medication. It stratifies patients extremely well, no matter their disease state, healthy or not, and it's very both state and trait-based. It is stable based on even genetic studies, but when people have a hit, stroke, death in the family of any type, it actually changes, and then it can improve if we intervene, whether that's through social or medical issues. And so she is right. The patients actually know quite well what is going on with them in a way sometimes better than we do, and I'm going to finish with that, but I want to begin just by saying, of all the things that we can capture and know, please don't forget what they're trying to tell us, because it's as powerful as what we can capture. ONC is an agency that I have now been at for 3 months. It is 10 years old and at a very interesting time in its trajectory. I'm certain that you're all familiar with us because you love the Meaningful Use program. Raise your hand if you love Meaningful Use. Thank you. The line will form outside when I leave. The agency was formed actually in 2004 and was established as a way to develop a national strategic plan and approach to health information technology, the technology for a fifth of our economy, to think about how we would, inside of the federal government, align ourselves between the VA, the DOD, SSA, other agencies, to have a shared agenda so that when we worked with the private sector, there would be a way that we could talk about how we're going to capture data, what are the standard ways, how we share it in private and secure ways, and how will we meaningfully use it to the betterment of our population's health. In 2009, there was an infusion of capital as a national priority around stimulus took hold, and in the HITECH Act, there were funds made available to a newly created agency called ONC that allowed the then agency to work with the private sector on building an infrastructure that would allow for standard data capture across the healthcare environment for certain eligible providers. This meant that for the lucky ones, they had the opportunity to participate in a program that has put out almost $22 billion in incentive funds that we were able to support through ONC to help with workflow redesign, to develop and implement standard data capture ways that you define elements. So what is it that, how we define blood pressure, for example, or smoking, and collect that at the point of care so it can be aggregated and be put to meaningful use on behalf of the patients. There were also other opportunities to build better workforce, to deal with HIT, and to share that information, not only through the pipes, there was money to build the pipes, but then, of course, to work at the population level to think about how we would turn all of our attention as communities on key important diseases that we selected and try to improve the population's health. This was our Beacon program that 17 communities across the country had a chance to participate in. So some 5 years later after HITECH, we see that now almost every hospital admission in this country happens in an environment where there's some kind of electronic health record. About 9 out of 10 hospitals have had the opportunity to participate in the Meaningful Use program. And we're seeing a rapid uptake of certified, standardized electronic health records in our country. And if you compare that to other nations that haven't made this sort of investment, it's a really dramatic increase. I think with all of that, it has brought us to the present day where we have some new challenges and opportunities. As we look ahead at ONC to our next 10 years, we are thinking about a few key issues and have some work going on inside of the agency that I'll share with you that's relevant to this idea of creating a learning health system. So the success in the rapid adoption for the eligible providers has meant that it becomes increasingly clear that some parts of the healthcare continuum do not have the opportunity to contribute to this grand amount of data in our learning health system. So importantly, that is where some of the most vulnerable and some of the most expensive patients are in our community. That's places like long-term post-acute care, behavioral health, dialysis, even in the EMS sector, we could get a pretty good list of places where we really need to find all the tools in the federal and private sector toolbox to see that care is captured across the continuum in a standardized way, using products that those parts of the healthcare continuum can buy off the shelf that are certified and as close as possible plug and play with the systems that you all have already put into place. This is a national imperative, frankly, for our patients and our population, because without the whole picture, it will be a major challenge to achieve this three-part aim, the aim of having better care at a better price and improving overall the population's health. At the same time, we know that there are some opportunities to improve the usability of the electronic health records, and that ties in closely with safety and some considerations now that as we have more opportunity to look at care in the clinical environment, to think about ways to reduce hospital infections, but also to think about ways that perhaps by improving the products, we can do a better job at getting the information to the clinician when they need it to save a life or make a life better. That would be in the work we're doing around safety, around clinical decision support in partnership with other agencies. And then I'm clearly, I hope y'all know, glossing over all the work we do, but I want to jump right to PCOR, which is another bundle of work that we are engaged in, which is the internal HHS work that is partnered with PCORI and PCORnet, and is a way that HHS tries to think about what are the ways that we can partner with the private sector and with consumers to do a better job of not just capturing data for the sake of improving care or achieving the three-part aim, but really leading to a system that improves the art and science of medicine. And beyond that, more importantly, improves the population's health, which is going to take more than medicine, since that is only a part of the equation. This is a dream that people had long before I showed up on the scene, and it's something that we are completely bought into. And every step that we take along the way at ONC and HHS is thinking through how do we make certain that we are attending to the important foundational elements that are going to allow that to be a reality. So what does that mean? That means that we have to increasingly pay attention to the fact that we cannot break the system along the way to collecting the data. If we're going to create the information necessary that is available to all Americans and not just some highly successful systems like the VA, like what has been described of my panelists by Intermountain Health or HCA. So a lot of parts of this country where that much data is not collected, not available, not being used in those kinds of ways to really improve patients' lives, and that is really our imperative. So we have to raise the floor, is what I'm trying to say. And to get there, it is about increasing adoption across the continuum. It's about being thoughtful and parsimonious about what we are collecting and expecting to collect at the point of care so that the providers can contribute, will make the data meaningful and robust so that we can feed it back not just to them to improve quality and safety in their practice, but also to improve overall health. It means that we must make a priority around interoperability. Interoperability is sometimes the last thing that an individual system thinks of, but I hope not, because you all know that consumers don't just use one tax ID number for their health care. They just don't, and they never will, at least in this country. Perhaps there are other places where it happens. They are going to shop based on personality, based on geography, based on the phase of the moon, based on all the things that we shop for, because we're all patients also. And so we must create an infrastructure that is open enough that if you collect information in your database, in your healthcare environment, whatever that might be, that it can be freed and flow to the benefit of that patient across the care continuum. It has to be available to save their life so that ultimately it can also be available to save the lives and improve the health of the entire population. This is big work. This is work that means that we have to define the right standards. We have to find a way to build the pipes so they're sustainable across time and not just experiments or not just closed to healthcare systems and vendors, but available to all, irrespective of ability to pay, color of your skin, geography, rural, urban. It means that we have to define privacy and security in a way that's palatable to all of us and protects people and their data, but also allows it to be put to good use. It means that we have to settle on the right governance infrastructure. We have to come to some agreement about who gets in, who is not, what to do when people aren't following the rules, and how we make the decisions as regions and then eventually as a country. So we are focused intensely on that, what we consider a national priority of seeing that we're not just focused anymore on capturing that data in a standardized way, but we're freeing it up so it is not just useful for big data, but is useful for patients as they move across the care continuum. So I want to end actually with a couple of words of caution, and then I'll sit down. One is that big data is really tempting. It's tempting to us at HHS. It's tempting to anyone in the private sector to begin to play with. But you all know that you need to walk into this with some a priori hypotheses because water is indeed wet. And if you watch television, you're likely to get cancer. But those two things are not necessarily causally associated. So let's be thoughtful about how we're using this data, and this sort of machine-driven analytics is fun, but it's not necessarily asking all the right questions all the time. Second, we need to be thoughtful, and we are, as we're developing our P-Core infrastructure, about not overburdening the front line, because at the end of the day, it's a healthcare system and it is designed to take care of patients. And there's lots of ways we can do it, but we certainly want to make sure that we are not over-standardizing and structuring data in such a way that we lose context and narrative, or prevent that care environment from being the rich place that patients and providers so enjoy. We want to be thoughtful about privacy and security. Not so much an issue probably for most of the folks in this room, but the flurry of activity around big data is exciting, and it's almost endless what we could do, but these are people's information, and discrimination is something that we should always have in our mind. Our shop is paying a lot of attention to that, trying to stay ahead of it in our privacy and security group, working with the White House and others, because we must protect people. I also would encourage you to loop back to my beginning and say that, so I'm going to pick on Steve Finn amongst other people in the room, but Steve and I had a lot of arguments about whether you could, and I'm so glad that Beth is here too, about whether you needed to use an SF-36 or a 12 or an 8 or a 4 or a 1. And I'm a lumper, so I went with one question in general: how would you rate your health? I spent all my time until Katrina working on that. Why? Because patients are great computers. People are great computers. They can synthesize a lot of data and give you information on the other end, and then you can dig into it if you need to. Why do I tell you that? Because there is also a temptation to collect and keep collecting more and more and more. And as you do that, it also tends to marginalize, due to worry about burden, the kinds of information that is rich and valuable and necessary from the people we're serving, who are the consumers, the patients, the individuals, call them what you want. This is really about them. Their voice matters, but so does their vote. And so please make room in your databases, make room in your collection for what it is that they want to share, because it's not only that we should show them what we think they have a valuable piece to contribute. Thank you all.